Well, we're going to talk about preventing disease transmission, and I just recently started a book called The Next Pandemic. It's like one of those edge of your seat books. It's really interesting, really good, by a guy named Ali Khan, and it looks at where these diseases come from, and some of them have very interesting stories of origins, and then why they're threatening global populations. And pandemic, of course, means a worldwide epidemic, right? Which we've had histories of. It is part of human history where large populations of people are wiped out by these little tiny organisms, right? So things to be aware of. And in fact, if we're honest, there's ways that we are contributing to this next pandemic, right? Because it's an inevitability that at some point in human future, we will see widespread plague that we can't control, or an infection process that we can't control. And is it possible that we're doing things as healthcare workers that's contributing to that? And like this chapter tells us, yeah, there are. So stop doing those things. Here's the objectives on how we're going to stop doing those things. We've talked about medical asepsis, but we'll come back to it, and we'll talk about disinfection, and probably one of the biggest ones we'll talk about today is isolation. And one of the big takeaway questions we'll ask is what to do when we're working with an isolation patient, right? We'll be defining different types of isolation and thinking practically how do we work with that. We'll talk about personal hygiene measures that help with the spread of infection. And these personal hygiene measures are things that I would encourage you to employ at all times, not just while you're at the hospital, but at all times with all people, right? Because they will promote your own personal hygiene and health, but it'll also prevent spread of disease to other people that you know and you care about. Because how awful would it be if you personally weren't susceptible to something, but you bring it home and the little one gets sick, right? Or your loved one gets sick, right? And then we'll talk about hand hygiene. I know that you probably are sick of hearing about hand hygiene at this point, but the reason that we talk about it so much is because people forget it, or they forget how they do it. I tried to work to get a black light in one of those hand hygiene kits that they use to teach hand washing to when you're in the hospital. It kind of blew my mind. I had worked in the hospital for I don't know, 10 years when I hired on at this new facility, and they did this hand washing check. And I was like, you got to be kidding me. Like, I wash my hands all the time. I know how to wash my hands. I'm pretty religious about it. But I totally failed it. And in fact, if you look at the textbook, it's an illustration of how to fail a hand washing test. So even this textbook doesn't have it right. If you notice, she's wearing a gigantic honking wedding ring. No. One of the first things we'll do is we'll take our ring off and we'll set it on the sink, and then we'll wash our hands. So if you ever have an opportunity to do one of these hand washing tests, what they do is they put an agent on it that will glow under a black light, right? You can't see it, but it will glow under a black light. Then you're instructed to just wash your hands the way that you normally do. And I always sing myself happy birthday. Happy birthday to Ben. And because that's about 30 seconds, right? And I do my whole hand washing routine, my fingers, my fingernails, all of that, and then you put them under the black light. And there were these giant places that I had missed on my hands, right? So it's very eye-opening to me that hand washing is a skill that we can continue to hone. That was after 10 years of practice. Still wasn't completely perfect at washing my hands. So we can continue to hone those techniques. We should not get sick of talking about that. And then we'll talk about linen disposal. And we're going to talk about the CDC and their role in preventing that pandemic. And we'll talk about how to get rid of contaminated junk. We'll talk about isolation techniques for infectious patients, people who could spread infection, and how to avoid spreading that infection by proper disposal of things and doing stuff without breaking isolation principles. And then finally, even though it's not on here, we will talk about patients who we don't want to spread infection to, right? Like patients, for example, who have cancer, or people who have some immune problem, like they've recently had, for example, a liver transplant, We do not want to spread infection to that individual. So we'll talk about those as well. Here's some key terms that are going to be helpful for us. AIDS, asepsis, disinfection, epidemic, health-associated infection, which is a new term to me. So the terminology continues to evolve. So I was interested in reading about that last night. And then MRSA, which we've already mentioned, this methicillin-resistant Staphylococcus aureus. MRSA or MARSA, different people say it differently. There's that term, pandemic. We'll talk about standard precautions. And just so you know, like if you're tracking with the terminology here, standard precautions, you'll hear people use other terms interchangeably. Standard precautions is pretty much what's there in most, like the OSHA documents and things like that, the government documents. But even within the government documents, they've used it interchangeably with universal precautions, right? Which, even though it's called universal precautions, doesn't include everything that standard precautions does. So it's kind of confusing. Why they use them interchangeably, I don't know. But you may hear people use those terms interchangeably. The accepted term now is standard precautions. So that's what you'll see on the registry. Sterilization, tuberculosis, vancomycin resistance enterococci, or VRE. That's a new one. That was another new thing to me, right? I was like, ooh, new stuff. We're building new super bugs. So that's what we're talking about when we talk about emerging diseases, ways that we are making new forms of disease, bloodborne pathogens and tuberculosis. One of the things that's been really striking to me is to kind of track the rise of Ebola in Africa. It's very interesting because there's parts of, like, for example, the Congo where there's fighting going on, right? And if you've been tracking this on the news, the people in the Congo are actually destroying and dismantling the aid stations that are sent there to treat Ebola, right? Either for superstitious reasons or as a way to cripple the local population. But that's really wild, right? To be actively fighting people who are there to help with an epidemic. So there's a complex things that occur that contribute to this. We're going to be mostly looking at those complex things as they relate to the healthcare system. But a lot of this stays pretty personal, right? A lot of this is pretty personal, so we will have some kind of personal discussions as we kind of go along. Okay, but to start with, emerging diseases on page 146 in our textbook. Epidemic just means literally a substantial increase. And so if we see an uptick in the number of disease cases in an area, we can call that an epidemic. And the CDC, the Centers for Disease Control and Prevention, is responsible for monitoring and looking at epidemics kind of in specifically in the United States, right? And they compile statistics, they release data about it in reports and annual surveys. They had a more significant role, particularly during World War II, where there was more biological warfare going on. And so they could do things like quarantine. They could control who's exiting and leaving certain areas, right? So they historically they had significant amounts of control over movements of U.S. citizens and military personnel and stuff like that. Largely right now they're regulatory and or just releasing scientific data, right? But there's some interesting case studies about CDC. Should they have more control? Should they not? We'll also look at World Health Organization. They do the same thing as the CDC, only they do it globally, right? So a lot of those reports on the Ebola, that's being released by the World Health Organization. So they offer a lot of interesting stuff, the CDC does, from everything from tuberculosis to HIV. And one of the things that we need to think about is, why do diseases emerge? Well, recently, last year, my family, we moved from Midtown, right? And we moved out to Raleigh, to a more rural area. It feels more like kind of like the the woods to me, out where we're at. And in Midtown, there were no ticks, right? There was no ticks in Midtown. It was a bigger population area. Ticks weren't something we worried about, right? But in Raleigh, there are a lot of ticks, right? Because it's more wooded. There's places where like ticks can reproduce or whatever. I don't know what ticks do to just kind of drop or pop out of hell or something. But so there's more ticks out there. So we've had to educate ourselves and check ourselves for these ticks, right? Why? Because they are what are ticks in terms of transmission of disease? Vehicle, vector, fomite. What are they?
Vector.
They are vectors, right? They're arthropods that can be reservoirs for disease and they can spread it. And particularly what we're interested in is the deer tick because it can spread Lyme disease, which just sounds awful to me, right? So these types of things, increases in human populations, the movements of human populations to and from places, education. Does the human population, do they understand that there's things like ticks that can spread Lyme disease, right? Do they know that? Have they received those CDC reports, whatever? Are they compliant? And then the fact that these pathogens mutate. So we can have resurgent or recurrent old diseases caused by a mutated pathogen, changed. And now we don't know, we don't have the treatments for it. That's what we're talking about when we talk about MRSA, methicillin-resistant Staphylococcus aureus. The staph mutated, and now we can't treat it with the stuff we used to treat it with. And it's not as simple as just coming up with a new thing to treat it with, because it gets pretty complicated at that point. Also, this is just speaks to the brokenness of the human condition. There are people who use pathogens as warfare agents, right? And so we have historical documents and even recent things, evidences of people doing just that, right? In fact, when SARS first came out, there was a question about whether or not it was a bioterrorism act, right? More recently, when I was in college, there was an outbreak of anthrax that was caused by a terrorist, right? It was just prior to 9/11. 9/11 kind of eclipsed it, but it was still significant. So that's why we have these departments of hospitals responsible for keeping up to date with the CDC recommendations and what's happening with the World Health Organization. So here's just kind of a nice breakdown of all of that I just mentioned. So can anyone think of any stories that go from your own life that map onto any one of these things? I'll hit pause on this. All right, healthcare associated infections, and this is, like I mentioned, is a new term, right? That we've started abbreviating it this way, HAIs. So we're saying that approximately 722,000 patients acquire a healthcare associated infection each year, right? And of those, due to the number of like about 75,000 people dying due to healthcare acquired infections, and this on page 147 in the textbook, I've underlined it here. It's now in the top 10 leading causes of death, right? And it's costing tens of billions of dollars to treat. Those are important numbers, just for the magnitude of them. I'm not going to ask you exactly how many people got healthcare-associated infections, but just for you to understand how widespread this is, why we're talking about this, how important it is. Some stuff that we're very concerned with are MRSA and VRE, right? So how do we spread these things? Well, contaminated hands, right? Contaminated instruments, urinary catheters, ventilators, these support devices that we use in the healthcare setting, right? It's not on this list, but I'm going to place it in there, that unhelpful collaboration. So we did that collaboration exercise earlier. If people don't collaborate, right? If people are not working interprofessionally or interdisciplinarily, then problems occur. And the people that I'm thinking of kind of top of my list right now is make sure that as an x-ray tech, you have a good working relationship with your nurses, right? Because the nurses, if they're doing what they're supposed to be doing, they should be informing you about precautions that patients have, et cetera, et cetera. Now, to go back a step or two, and we'll come back to this, but one of the big scares in the healthcare setting is HIV and AIDS, right? Because this is kind of weird, but in current law, if a patient has AIDS or HIV, they can request that no one know that. Like, so say they need a knee transplant, right? They are not in the hospital for anything other than a knee transplant. They can request that no one in the hospital know that they have HIV or AIDS. That's a significant stressor to people who are working in that environment, right? Yeah?
If that were to be the case, would that not be included in their chart or anything?
It doesn't have to be.
Okay.
Because they are just there for a knee replacement. So all that's in their chart is just, patient is here for a knee replacement, right? For the knee replacement, there's not necessarily any reason to do the blood work that would detect HIV. But what I've found, I probably shouldn't put this on YouTube, right? There is the grapevine, right? We all know about the grapevine. And this is one time where the grapevine could be your friend. That if you've cultivated good interdisciplinary communication habits with nurses, guess what nurses know? I don't know, I think they got telepathy or something. Some nurses, I think, literally have like grown extra eyes in the backs of their heads or something. They have a sense for this stuff, and they'll give you a warning, like on the DL. And that has become pretty normative, right, as a response to this genuine threat that's there because of the legal environment. And one thing that I want to point out is, so I mentioned how that feels insidious or stressful or threatening, right? One of the things that we'll come back to over and over and over again, if we're dealing with someone who has, for example, MRSA or VRE, or HIV or tuberculosis or whatever, please continue to work with that individual as a human being, right? Please continue to interact with them with the same amount of respect and dignity and care that you would hope that someone interacts with you or with someone you care about, like your mom, right? Because they're already under a significant amount of stress and probably shame for having this disease, and so we don't need to just add to that, right? On page 148 with MRSA, you may be wondering, what do we do to prevent spread of MRSA, right? Well, the main thing that we're going to be doing is taking care that if we're working with someone who has MRSA, we are using what we call contact precautions, right? So we'll be talking about that here in just a minute. Another one that's pretty common and that's kind of creepy is C. diff. So there at the bottom of page 148, this talks about Clostridium difficile colitis. We just call it C. diff. It is interesting in that it actually has evolved largely in response to people using too much hand sanitizer, right? Using too much hand sanitizer. So that's why, again, I think proper hand washing is important, because some of these other things that are more convenient, like the alcohol rubs or whatever, have contributed to the rise of C. diff. So and the reason I say that is it cannot be eliminated by routine asepsis methods. So it has to be washed off. It's a spore, right, that's there on the skin. And the alcohol, you would just be rubbing the spore around. Does that make sense? The alcohol can't break the capsule of the spore. So if I'm hand washing, though, I'm washing the spores off of my skin. Okay? And this is a risk to patients who are on antibiotics, that I could then spread the C. diff to them and they get this healthcare acquired infection, right, because they're immune compromised. All right, the bloodborne pathogens are some of the scariest, and I know I've already scared us a little bit about it, but the occupational risk for these things is not great, right? And I underline that here on page 149. The occupational risk is not great, right? So this is not a significant safety hazard for us in the healthcare environment if we're doing what we're supposed to be doing. Where is it a risk to us? Primarily in our personal lives. That's why I bring up the personal life thing. That as we see society move towards looser standards in terms of sexual partners or whatever, we start to see these diseases as well, right? So please continue to practice caution in that area. But so AIDS is not contacted by casual touch, right? You can eat a burrito that someone with AIDS made, right? You can shake hands with someone with AIDS. You can kiss them on the cheek, right? All of the ways that you normally interact with people, you can interact with them except one, right? Yeah, don't have sex with them. That's it. Now, where this is important for us, and so hopefully none of us are thinking about that as we pursue a career in X-ray, but we do have to be careful about things like blood and needles, right? Because this is a bloodborne pathogen, and it's actually a very interesting pathogen how it works. It's called a retrovirus, which means that it reprograms your own DNA. Pretty wild. But we want to be careful with, particularly for us in healthcare worker, blood and needles, right? So this is one of the reasons why we're going to continue to use certain precautions. Now, here in the United States, even though globally AIDS is a significant thing, here in the United States, it's a pretty small population, pretty small number of people. And we can track it due to certain kind of risky behaviors, risky life choices, and things like that. So I underline this entire paragraph, though. I'm just reiterating that earlier point. As a healthcare worker in today's world, you must expect to encounter unidentified or undiagnosed cases of AIDS or other blood-borne diseases like hepatitis. The patient's right to confidentiality regarding AIDS diagnosis within the healthcare setting prevents healthcare workers from being informed about diagnosed cases, and additional undiagnosed cases may be encountered as well. So let's talk a little bit about the needle stick part. The probability of infection following a needle stick injury with blood-containing HIV is only 3 out of 1,000 exposures, so it's a 0.3% risk, right? The risk of infection from exposures to mucous membranes is as 0.09% risk. So that's a very small risk, right? That you could just be walking down the hallway and, for example, someone spits or someone, like, blood flies through the air or something, and it would pass in through the mouth or something like that, right? Those are the two ways that we're worried about. The risk of the second one that I mentioned is really low. The risk of the needle stick thing is something that we need to be aware of. So avoid needle sticks. Okay, with hepatitis, there's a lot that we can say about hepatitis. The main population that we are concerned with getting hepatitis is intravenous drug users, right? And this is the reason why some programs for clean needles and stuff like that exist, right? So we're trying to prevent spread of hepatitis. Have I known healthcare workers who have gotten hepatitis? Yeah, I have. So is it a risk? Yeah, it is. For most people, it results in liver disease, right? Some of it we can treat, and some of it we can't. So one of the things that we've done is ask that you receive a vaccine for hepatitis A and B here at the school, right? That is going to prevent your receiving those, right? And hepatitis C, we do not have. Yeah.
So I know, like, for me, I wasn't immune to Hep B, even though I got the series when I was younger, and I didn't know until I came here, and then I had to get the whole series. But I'm immune now. But, but that goes to say, like, a lot of people might not know that they're not immune to Hep B. So
Yeah.
is that?
Wasn't either had to get the shots again.
Yeah.
I think we all do.
Yeah. Yeah, to your point, I think a lot of people, once you start in the hospital, you're required to get it. Interestingly enough, I think it's a great thing that we require it just here at the school. I think that's part of the philosophy behind that policy is we recognize at the college that some people think they have it and they don't. When I went to my school, they did not have that policy. And so it wasn't until I literally was employed by the hospital that I received the vaccine. I had been working there as a student for 2 years, and they finally vaccinated me. So it's a good policy. You know, I know it's a little annoying or whatever to have the health record holds, but it's a good policy. Let's talk a little bit about accidental needle stick, right? This is on page 151 in the textbook. If you are accidentally, these can occur, right? They can occur. So be very mindful of how you're working with needles and follow the procedures that are there at the hospital, and make sure that you receive full training on how to work with needles prior to doing anything with needles, right? But should you be contaminated, the very first, and the skin is broken, the first thing you need to do is don't put a bandage on it. Hold it over the sink and run water over it. You're trying to flush it out, right? So hold the wound over a sink and run water over it, wash it with soap, and wash down in the wound, right, as much as you can, yeah.
Does it make any difference if you like kind of squeeze to make the blood come out, or is
It might. I mean, that's like the old like Smoky Mountain snake bite thing is
My
to
dad does that.
squeeze the venom out. It might. I don't know. I've not read enough on it to know, but it's the same idea that you're trying to prevent. If it got in, generally blood flows out of the body, not into the body, but if the needle broke the skin, can I get the stuff out of my body is the question. So don't bandage it, right? You don't want to hold pressure there, right? Like what you're normally told to do with a wound. Don't hold pressure. Wash it out, flush it out. And then, of course, you're going to have to fill out an incident report. So fill out the proper documentation, and they'll probably do some testing on you and stuff like that to make sure that you weren't exposed and it didn't become an active contamination. The other thing is it's helpful to be aware of all the different PEP, right, or the post-exposure prophylaxis things that are there at the facility. So once you've been exposed to it, what are the steps that they would expect you to follow? Generally, it's a visit to the ER. Okay. On the front end, right, ways to prevent the needle stick from ever happening is, again, being educated on needle usage prior to using the needles, being aware where your sharps container is and how to use the sharps container, and when to empty it, et cetera, and then using PPE, personal protective equipment, things like gloves, stuff like that. Okay. If for whatever reason you are splashed, right, like the awful thing I mentioned earlier is there's blood flying through the air and you're not wearing a mask, you're not wearing eye cover, and the blood goes into your eyes. What do, right? It's the same basic idea. We want to wash the eyes out. We want to rinse the mouth out. Now I'm going to tell you kind of a gross story. I was working as a brand new student, probably had only been at the hospital for about a month. I was assisting on a fluoro procedure where we were replacing a feeding tube in a patient, right? And the technologist, I'm not going to mention her name, but she was a little loopy, right? Wasn't anyone who works here. So the doctor's there, he's feeding the feeding tube in, he's getting some resistance, so he has to retract the feeding tube. He hands it to the technologist. I can't remember if I said something or whatever, but she turns around and smacks me in the mouth with the feeding tube, right? right in the face. And it was disgusting. It was really gross. The doctor started laughing. He thought it was really funny. And so she turned around to see what he was laughing at and smacked him in the face with the feeding tube. He didn't laugh about that. But yeah, can these types of things happen? Yes. The best thing you can do, though, is to just be aware of when you're working with patients or on a procedure that has that risk for a splash or something like that. Even if no one else is wearing a mask, go ahead and put a mask on. You know, like in the back of my mind now, and people will tease you like, "Why are you putting a mask on? We're just doing this feeding tube." Well, you've never been slapped in the face with a feeding tube, so bad on you when it happens. Okay, another one that's kind of sneaky and that we worry about quite a bit is tuberculosis. And I know that Mr. Wolf has mentioned to you, here's an actual x-ray of really advanced tuberculosis. And so what we see here is cavitation, because the body tries to form a calcification around the area of infection. And we actually have an air fluid level inside that cavitation. We can see fluid, and that's why it's got this like level to it. So this patient's upright, and then a portion of air inside that cavity. So this is an airborne lung disease caused by a bacteria. The patients that we're dealing with here in the United States generally are homeless, immigrants, immune compromised, alcoholics, people who have a high amount of disease around them, right? And they're immune compromised, right? You can be around tuberculosis if you're healthy, and your body will fight it off. Your body will fight it off. But this is a significant part of pre-employment screening, especially after a known exposure. So there will be patients who come in, and it will say, all it's going to say is you're doing a chest x-ray, and it will say TB, right? And you're thinking this, right? But it may just be part of their screening. So get some good history for them. Why are we doing this exam today, right? And in the back of your mind, you're thinking, does this person need to be wearing a mask? Do I need to be wearing a mask? You're kind of watching them to see how best to proceed with the procedure. Generally, someone who has active TB is going to be already in isolation and all of that, but could a patient walk through, a clinic door with active TB? Yes. So get a good history, try to figure out why you're doing what you're doing. At the same time, don't freak out. Like if you get that exam requisition for a chest x-ray and it says TB on it, don't immediately call Deborah and say, "Oh my goodness, I'm working with a TB patient." I hate to tell you, but no, it's a big gray area. It's a big gray area, so use some critical thought about that. One thing that is important to know about TB on page 151 is if what we're worried about is airborne droplets, right? And they're pretty large in size. But then there's this smaller thing, these particles that have a protective waxy coat around them. These particles of the bacteria. They can live on surfaces for years, right? So chances are there is TB particles in this room, right? You know what I'm saying? Like chances are there's a TB particle in any exam room that you walk into. So what do you do with that? I'm asking you, what do we do with that?
Don't touch it.
Okay, become a germaphobe and don't touch anything? That's one solution. I've seen people go down that road. It doesn't get pretty. Other things?
Protect yourself, like wear gloves.
Wear gloves, good. What else?
Treat every room the same as you would a room where you can get infected.
Basically treat everyone like they have tuberculosis and AIDS, right? What else? There's one other thing I'm looking for. You were close to it, Miss Ryan. Clean, 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 right? That's like they say in real estate, the most important things are location, location, location. The most important thing in the hospital is clean, 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 right? Cleanliness is next to godliness, like they say. I think that's like the unofficial Baptist motto. No, clean everything. Clean it all. Clean, clean, clean. If you want to have a job this time next year, one of the best things you can do is just be a neat freak and just clean. If there's downtime, clean, right? If ask them where the cleaning solutions are and clean everything, right? You will really get a feel for whether or not you even want to work in this facility. They don't even know where the cleaning supplies are. Well, you know what? Sorry, not interested. I'll work someplace that's a little bit more clean. Some of the best techs I've known are the cleanest. And to go back to my girlfriends, the machines, they like to be clean as well. Computers love to be clean. They don't like dirt, all that. Okay. Preventing this disease transmission stuff, right? This is on page 153. So, a little bit of historical stuff. We used to have universal precautions, but that's evolved now to just include both universal precautions and the body substance precautions that we had in the past, and we now call that standard precautions. But like I mentioned earlier, sometimes those terms are interrelated. And the purple box on page 154, standard precautions apply to blood, all body fluids, secretions, non-intact skin, and mucous membranes, right? And this is kind of a more professional way of saying what I said earlier, the second box. Remember, the key to effective protection using standard precautions is using a consistent approach to all contact with all body substances of all patients at all times, right? And I would not just say all patients, I would say all people at all times, right? To go back to kind of recommendations on dating life stuff. Medical asepsis is going to help us reduce the probability of infectious organisms being transmitted, right? So this is things like what we talked about earlier with disposing of things appropriately, disinfecting, cleaning surfaces, right? Knowing if something is sterile, understanding appropriate activities around a sterile field, right? So, generally we don't do quarantines anymore, right? But in the past what we would say is no one can enter or leave a house during a time of infection. So out of the quarantine we now have what we call isolation. Here are the things that we can isolate for, right? And these are things that would be more at the national level that the CDC could legislate isolation on. So these are the things that we used to use in the past, right? Universal precautions and body substance precautions. Well, like I said, those have been combined into the standard precautions, right? It's the current infection control system, right? And these include precautions for airborne, droplet, and contact, right? Which is a lot of what we've been talking about so far. MRSA is contact, airborne stuff is stuff like tuberculosis, and droplet tuberculosis as well. I told y'all I don't like splitting hairs about airborne versus droplet. I don't have an electron microscope. So OSHA also publishes these bloodborne pathogen standards, right? And there's stuff that's there at the work site that will describe to you what to do in the event of various biohazardous materials, right? So there should be signs and labels. We all know the biohazard symbol, right? Familiar with that symbol. And generally, if it's red, right, just stay the heck away from it. In the hospital, if it's red, the only thing that's red that you might use occasionally for something other than like housing bloodborne pathogens is certain electrical sockets are red because they're hooked up to the generator system, right? Pretty much everything else that is red is labeled red because of OSHA bloodborne pathogen standards. All right. Medical asepsis. the one term I haven't really mentioned yet is microbial dilution, right? Is this process of reducing the number of organisms. One of the things that I think about, this may not be the best example of it, but to go back to after the needle stick, flushing water over the wound is essentially a practice of microbial dilution, right? Getting rid of the stuff that's there. All right. Hand hygiene and how to do it and how not to do it. We need to wash for at least 30 to 60 seconds with soap and water, right? And like I mentioned with the C. diff, this is the only way to remove those spores from our hands. I think it is best to remove your ring prior to hand washing, right? And to clean it separately. The alcohol-based rubs, I think that this slide might be slightly wrong in terms of saying it's more effective at killing some stuff, such as C. difficile. I don't think that's quite right. So clearly there's continuing research going on there. But the nice thing about the alcohol rubs is they're more convenient than sinks, right? So we see a lot of them now, kind of all over the place. One thing to be aware of is if you're wearing artificial nails, those can become a reservoir for infection, right? So I would say don't use artificial nails. I think that there's a policy against it here at the college. And like I mentioned, this aseptic hand washing technique, I've got right here, what's wrong with this picture, right? We can see where the individual has done some things correctly. Like particularly, I think using the hand towel to turn off the sink, that's smart, right? One of the dirtiest places in a hospital is a doorknob, right? So good facilities and stuff, they'll have ways to open the doors with your feet or something like that. So some general techniques for cleaning. So we said clean, 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 because it helps us get rid of pathogens on fomites. In general, we want to clean from the least contaminated area towards the more contaminated area, and from top down, right? I always think about, like when I'm teaching my kids how to wash up in the shower, right, or whatever. I tell them, okay, you start with shampooing your hair, and then you work down from there, right? It's the same thing in cleaning the department. Start higher up and work down, right? Because you're sweeping that bad stuff down towards the floor. Avoid raising dust. Avoid contaminating yourself or other areas that are clean. And there's a number of recommendations for different types of cleaning solutions, right? Like bleach. If you've got a contaminated item or waste, right? Don't shake a blanket out, right? Or something that's covering a table. So I know that sometimes at home, like we'll shake the sheet out in order to get it nice and laid out. Now, if it's a clean sheet or whatever, sure, feel free to shake it out. But if you're cleaning up after a procedure, fold the thing towards the middle, right? Because I don't know what might be in there, right? So the very first thing I generally do is make sure I've done my needle count. I know where all the needles are. All the needles have been disposed of. Then I fold the sheets up, right? Because I wouldn't want to be folding up a sheet and fold up a needle. That would be a big deal, right? You would want to avoid that. And then drop them in the appropriate hamper. Sharps containers are there for the disposal of needles. So this is what a sharps container looks like. It will be red. It has like a little mail delivery slot where you drop the needle, right? In general, we don't do things like recap needles that people used to do in the past. Once we're done with the needle, we just drop it in the sharps container. Some IV supplies, we'll look at those around this time next year, how to do IV placement. They have needles that retract. Now, some of this stuff is going to be facility specific, so be aware of how they handle things like blood-drenched tissues and things like that, because each facility is a little bit different. I worked at one hospital, and their policy for disposal of blood contaminated sheets was to just put them in the normal laundry. And at the orientation, I raised my hand. I said, and as well as if the sheet had any tissue on it, to place it in the normal laundry. And so I asked the HR people, so you're telling me, if there's a bloody kidney on a sheet, you want me to wad up that sheet and put it in the laundry? And they're like, yes. And that was like the beginning of me realizing I don't want to work at this place, right? So they do have specific things. How those people sleep at night, I don't know. But here's the general things that you should see. Biohazard red and that sign there for zombies. And then this is what a sharps container looks like. And with this one, I think the drop slot is up top, right? This is just here to let me know if it's full or not. I can see if it's filling up. Now, just like the garbage can or the laundry hamper at home, the sharps container is no different. It's or the sink with the dirty dishes in it. It's like everyone's gonna try to pile that last dirty dish in the sink. The same thing happens with sharps containers, which is not a good idea. So they have a little line on them that says dispose of the sharps container here, because they know you're gonna continue to cram as many sharps as you can in there. Not a good idea. Just go ahead and find a new one or have it close at hand. Okay, isolation techniques. When we have questions about certain individuals either being more susceptible to disease or being a disease spreading agent, we practice what we call isolation, patient isolation. And it is based on how that disease is transmitted, right? So to go back to the cycle of infection, we're trying to pull out one of those arrows, right? Try to remove this transmission arrow, how it exits and how it gets to other people. So each isolation technique is based on that. So these are the types of signs you should train your eyes to look for. Now the colors are slightly different at different facilities. But one of the things that you can ask while you're visiting, right, is where do they generally label patients who are in isolation? Is that label outside of the room? Is there a cart? Is it in the patient's chart? How do they label those precautions, those isolation precautions, right? But the big three that we look at are contact, airborne, and droplet. Contact, airborne, and droplet. So let's look at each one of those. For the airborne precautions, the slides aren't going to be super helpful for us right here. But looking at the book, if we've got airborne precautions, we're generally talking about tuberculosis, right? Active TB. Remember that creepy looking chest x-ray, right? Active TB. They will be in a special isolation room that is filtering all the air in that room. Because like I said, how long can the TB in that little waxy coating sit on a surface? Years. So that room is basically a gigantic mess. You can clean it all you want, but that stuff it's got a waxy coat around it, so it's got a protective coat around it. You will be fitted, if you're going to be working with someone who's got active TB, with one of these duckbill N95 masks, right? And it'll have to be specifically fitted to your face. If you have facial hair and you're working in a facility that routinely treats people with tuberculosis, you'll want to remove the facial hair. So that is airborne precautions, right? Things like tuberculosis. Droplet precautions, and this is, like I said, I'm not going to go splitting hairs on droplet precautions. You won't see them very often, right? It is different from tuberculosis, right? But it's things like pneumonia and influenza, right? Now, do I still need to be careful if I'm working with patients who have pneumonia and influenza? Yes, I do, right? Should I wear maybe a yellow gown or something like that, and some gloves, and maybe a surgical mask? Yes, I do. Do I need to wear an N95 mask? No, I don't. Because all I'm worried about is if they cough and the sputum strikes me in the mouth, right? Or strikes me in the eye. That's what would be required to happen for droplet. So as long as I'm avoiding the patient while they're coughing or they're wearing a surgical mask, we're good. So in general, the way that clinics are handling this precaution now is you'll see a sign in the waiting room, if you have a cough, please wear a mask. Right? And so what are you doing? You're isolating yourself. I'm saying, I got a cough, I'm concerned about droplet precautions, I have a mask, right? Just so we're real clear on this, that's protecting you. Them wearing a mask is protecting you. So that's generally how it's handled, right? Now we can't just assume that just because someone is wearing a mask that they have an active precaution. Like for example, if a person in the Baptist system can't receive the flu vaccine, they have to wear a mask throughout the entire flu season. It's cray-cray, but that's the way they handle it, right? I don't know. All right. The final one is going to be contact precautions, right? And this is that MRSA VRE stuff. And so, in general, when we're working with a patient who's infected, we're going to be using this two technologist technique, right? One technologist in this instance will be the dirty tech. They will be wearing, before they ever walk into the patient's room, they'll put on their lead apron, they'll put on a gown over the lead apron, they'll put on gloves, they'll put on a hair covering, they'll put on a mask, right? And they are going to be moving the patient around and coming into contact with the patient, trying to limit that contact, but placing things like the image receptor behind the patient. Anything this person touches, we're assuming is dirty, right? That's why they're the dirty tech, right? The other person's going to be called the clean tech, right? They will only handle the equipment. They'll only handle the equipment. They will pull the image receptor out of the plastic bag that the dirty tech is holding. They'll run it and do the processing and all those types of things, right? So we have examples of that here. A description of how to do all of that on page 163 with illustrations, right? Now, having said that, I need to flip the script. And this is a common place that they like to test, right? Because I just described to you what to do if a person has contact precautions. In this case, the dirty tech handles patient contact and the clean tech handles all the equipment for contact precautions. Now let's ask, if the person has recently had a liver transplant or a heart transplant, how do we handle that? Right? It's the exact opposite. You just came to work and it's opposite day. Remember opposite day? So we sometimes call this protective precautions or neutropenic precautions. The idea being the patient is susceptible. They had a heart transplant. They are on immune suppressants. They are susceptible to become contaminated by me, right? So in this situation, I'm wearing a mask and a gown and everything to protect them. So who is the clean tech now? The one working with the patient. And who is the dirty tech? The one messing with the equipment. So it is total opposite day. So if we're dealing with an immune compromised patient, the person working with the patient is clean, the person working with the equipment is dirty. If we're working with someone that's got active MRSA or a contact precaution, the person working with the patient is dirty, the person working with the equipment is clean. And one thing to be aware of, last thing, if you're asked to transport patients who have any kind of precaution around them, particularly the contact precaution or the active TB precautions, be aware of what the expectations are for you to, what you should be wearing during transport. Is it okay for you to continue to be wearing like your gown and your mask and all of that? Or should you have removed that when you exited the room? Ask the nurse or ask the people there, what's the policy here for transporting someone who's got this precaution? So here's that. Older terminology you might still hear people use is reverse isolation. We generally don't call it that anymore. Here's examples of how to put on the hat and the mask. Generally, I put the hat on first, and then you put the mask on over the hat. And there's the gown. Right? Now, every now and then they like to ask questions about what order should this stuff be removed, right? But I didn't see anything in our textbook kind of outlining that. Oh yeah, here we go. On page 166, it has the order of removal. You can see she's removed the gown first, right? Then the gloves, and put both the gown and the gloves in the wastebasket. Now she's removing the mask and the hat, and then hand sanitizing. So gown, gloves, mask, hat, then hand sanitize. And here's just an example of what we're talking about. In this instance, if this is a patient, right, who's got tuberculosis, which one of these is the clean tech? Yeah, this is our clean tech for a tuberculosis patient, right? If it's a heart patient, which one is our clean tech? Yeah, Miss Daisy Flower over here.